basically, I will not go over the precision oncology as a field, because you'll be hearing from distinguished speaker throughout the 2 days. But I will try to highlight few things that, you know, and mention, reflect on our experience in the region. So as you know, where is the pointer? I took it, so it's my on the. So okay. So as you know, we start, you know, patients coming to you with symptoms, have imaging, then you have pathological diagnosis, and we do now multiple tests, you know, in different ways for panomic is called, not, you know, panomic. So you can do any test that is molecular and other genetics testing and so on to try to identify targets for treatment. And then if you look at the cell cycle that was published about the cell, I mean, the hallmarks of cancers, I'm sorry. So if you look at the hallmark of cancer cells, you will find now in each category of the hallmark, there are therapeutic development in that area. So the oncology field becoming extremely exciting and interesting and becoming much more complex. And then if you see, you know, from starting with the rituximab as first targeted drug, then Herceptin, then, you know, imatinib, and now we have almost 100 plus target therapy approved by the FDA. And the story of lung cancer, I will try to talk about it later briefly. But however, you know, you can imagine there will be ethnic difference between different population, and they call it pharmacoethnicity. It could be related to the environment, could be related to the genetics, drug-drug interaction, and local practice differences. So if we are going to implement cancer precision oncology, we have done this driver model a few years ago. It was simplified if you look at it in the current perspective, but at that time, we used to call it personalized therapy. And basically, it's built on trying to get good tissue, do good tests, the test that you need to make a decision, and then you need to have the drug that target that you know, that actionable mutation that you identify. And then for each one of them, you have multiple things you have to do as an institution and as teams to be able to get this done. So, but now, you know, I try to categorize the challenges into 3 categories. One is related to the diagnosis of cancer, the second is related to the patients, and the third is related to the access to treatment. So obtaining adequate tissue, we still, whether we like it or not, with all the advances, we still need to get good tissue up front till now. A few years down the road, we may not need to do that. We may do it by the blood, but for now, till now, we still need to have tissue, especially in the lung. Therefore, we need a multidisciplinary team. As you know, probably many of you serve in teams or be part of team, and we see how the discussion comes, where to get the tissue. And sometimes not in the initial diagnosis, but in the subsequent workup of the patients when we are looking for resistant genes. Liquid biopsy may overcome many of these challenges, but our experience now, we have tested more than 40 patients for ctDNA liquid, and we have 2 positive only. While in the literature, it tell you the literature tell you it should be around 60%. So there is challenge in that, you know, but this will eventually, when we improve the technology or have reliable labs that does that, will minimize getting regular biopsies. So we have issue accessing the test, even in the National Guard. So I mean, you know, I'm talking at the National Guard, but also this is reflective to all of you probably in the room, and you know, happy to hear from you if there's different opinion. We have financial issue, logistic issue, how to do the test. So even if you find somebody say, I'm going to pay the expenses for you, you still have issue with the logistic, how to get the things done. And then sometimes interpreting the data, and especially now if we move to next-gen sequencing, we really need people who are expert in bioinformatics to help us, you know, figure out what we need to do with the data that we have in the future. And David may touch in that. because in Oxford they have a lot of support in bioinformatics. Our patients come to us with advanced stage and poor performance status, lack of screening program. So even if the patient come to you with disease that you may end up discovering that they have good target, it will be too late. And we discover somebody, for example, who has mutation, but he is intubated. It happens actually with us, because it is too far advanced, in terms of the patient's condition and so on. Limited patients engagement. We have many of our patients don't know their diagnosis or deny that they know their diagnosis. We have cultural, social issues, and so on, convincing people about repeating the biopsy when you don't have enough tissue and so on. So there are challenges there. Again, we talked about the patient's conditions, the performance status, and comorbidities, and the ethnic differences. We touched on that, and I will go specifically over our studies that we have done. The medications are expensive. We have a formulary issue because the new medication coming very fast. By the time you get one medication in the formulary, you have another new medication that is FDA approved and that has good result. And I know some hospitals even close the door of having any medication added to the formulary because of budget issue. And even some hospitals, even when they have the medication in the past on the formulary, they stop buying the medications. So I will just mention one study we have done in the Middle East, and then talk about the journey of lung cancer briefly. So we have done the study basically to look at druggable targets in lung cancer in the Middle East. And we have 5 countries, 8 centers from 5 countries, more than 566 patients participated in the study. It was retrospective, actually, included in the study with IRB approval and so on. And so we get demographic information and pathological information. The majority were males, 78% were male, median age 61, 50% are smokers, current or ex-smokers. 2/3 are stage 4. We get all comers, by the way. So we tell them any patients with lung cancer, consecutive patients with lung cancer, give us data about them. The test was done on 29% of the patients. Even in stage 4, less than 40% of the patients tested, and it ranges between country, and it's not the time now to talk which country does what. But basically, about 1/3 of stage 4 lung cancer patients are tested in these countries, and then in 42 were positive, so 25% were positive for EGFR, and for ALK 7.9 were positive. The EGFR mutation was 31% in stage 4 lung cancer cases. So 1/3 of our patients' population will have EGFR mutation, which is in the middle between the Western population and the Eastern, Far Eastern population. So we are in the middle. That has an implication, by the way. So if I have a patient who failed stage 1, failed line 1, and then probably line 2, and he failed immunotherapy, failed systemic therapy, and I don't have access to getting EGFR, and he fits the criteria, for example, non-smoker, female, and so on, in our patient's population, you may be able to give TKI, because 1/3 of the time it may work. So it has a meaning in terms of the practical aspects. So look at the reasons, and it may sound strange that the physician were surveyed, 62% don't know what to do. Okay, I may know patients need EGFR, but whom I talk to, where I go to, what will be the first step to get EGFR testing? And the lack of funding was only 11%, insufficient tissue 10%, and different other reasons. So when you look at univariate analysis, gender, female, and TTF1 positivity were positive marker, positive predictor. And then when you look at the multivariate analysis, stage 4 has 3 times the ratio of having EGFR positivity than lower stage. So small fraction of the patients are tested, and you say no, we do more now. We do 80-90% EGFR, but what about RAS1? What about ALK? What about BRAF? We do 0 BRAF. So they're all in the guideline. I'll show you now. So this is the lung cancer journey story. So we started, and this is actually, I've been here now 11 years in the kingdom. And, I lived this step by step, and, we get a new test, and then I have to make sure that we implement it, we disseminate it. We get it, we implement it, we disseminate it. So initially we have to deal with non-small cell lung cancer. General, doesn't matter. Then we say histology is very important because, you cannot give, a vaccine for squamous cell cancer, so you need to know. You cannot give pemetrexate to squamous cell, okay? Then we start doing EGFR testing. So again, we get even companies to sponsor the EGFR testing throughout the kingdom. And yet, many times we have difficulty getting it in different hospitals because I open study for multi-site studies for both to check for EGFR and using Tarceva. And I have found many good tertiary hospitals, they could not get either the logistic or the company or get the lab. Okay, we settled that, Lab 21 can do. All of a sudden came the ALK. I need you, those who were with me in the journey, to remember this. ALK. Oh, the ALK has to be what? Has to be fish. Now you have to send, Lab 21 doesn't do fish. So you have to find another lab. We spent almost a year trying to find a lab who do the fish. And then initially, in the initial phase, I'm talking about now, it's easy, So then you do the fish. You have to send the specimen to fish lab and specimen for EGFR ALK. And then, okay, so you pass that stage, and then come ROS1, then, okay, got ROS1. Now you get T790, you have to do T790, and you have to do it in the serum and in the we push so hard to get it in the serum, and the company sponsored it. We have sent the specimen, so it was not financial issue. And now we have, the yield was not as expected. So now we have to look again. We are actually talking to Tony, Mark, and other people to see if we find specific lab for just the serum T790 testing, only the T790. Okay, but okay, let's say we can put that under control. Here come BDL1 now. So you have to test for BDL1. And after BDL1 now, it's in the guideline. I'm showing you a CCN guideline. Who does BRAF? Do we do BRAF? We don't do BRAF. Then look at this. You have to do MET, RET, and HER2. And these are guidelines. These are in CCN. I'm not telling you future kind of thing. So these are in the NCCN guideline. And we don't do that. In the National Guard, we don't do them routinely. Now, the solution is to get next-gen sequencing. That will do everything. And probably King Faisal and the National Guard are working on that and or probably start doing it. Will resolve many of the issues. But that is struggle. That's a struggle. Well, in the US, you can order it and then they send it to a lab, done, boom, you have the result and you do whatever you want. Here we have to struggle to get it. And it's not financial most of the time. Many times it's not financial. It's just the logistic and the system. So the final slide is we need to bring the new technology to the region. Next-gen sequencing should be adapted. Before 2017 end, we should be doing next-gen sequencing for our patients in the kingdom. Really. So this should be our goal. And we'll be hearing, during the session, each disease, I need each disease in each session to push for his disease area to make sure that he is getting everything he wants in the kingdom. This is not just for scientific exercise and changing nice ideas. I need you guys to push to get the test optimal here. If we cannot now, we send it out, but in the process of making sure that it's done here. So we need to train people. I think our pathologists are good. We need, but to make sure that there's a new generation coming with focusing on this. Bioinformatics, we don't have much in the kingdom. We need to educate the population better. We need to educate the healthcare professionals, not just medical oncologists. And we need to prioritize treatment selection, the cost effectiveness, pharmacoeconomic issue. We have to work on that and then write our own guideline. By this, I'll stop here and thank you very much.